Welcome to the Fragility Forum 2022 podcast series produced by the Fragility, Conflict and Violence Group of the World Bank Group. As complexity and uncertainty become the new normal, with complex crises posing new challenges, from the COVID-19 pandemic to climate change, this podcast series explores how the international community can best support countries affected by fragility, conflict and violence in a fast-changing global landscape.
Hello and welcome to this podcast for the Fragility Forum 2022, hosted by KIT, the Royal Tropical Institute in Amsterdam. My name is Bipasha van der Zijde. I'm a communications advisor at KIT. In this podcast, I'll be speaking to three researchers about health system strengthening and institution building in fragile, conflict and violence-affected settings. We'll discuss two countries where KIT has worked. Both the countries use the so-called contracting out models for basic healthcare service delivery. These contracting out models are where NGOs are contracted by the government or another contractor working on behalf of the government to provide healthcare services instead of the government itself. Using these models as a way to provide basic services in fragile states has gained popularity over the last 2 decades as a way to rapidly expand service delivery. We'll ask our speakers to reflect on their experiences working within or for these contracting out systems, their potential benefits and the trade-offs. In the first half of this podcast, I'll speak to Dr. Ahmad Shah Salehi, a health economist and former advisor to the Afghan government. KIT has worked most recently in Afghanistan as a third-party monitor for the Sehatmandi project. Funded by the World Bank and managed by the Afghan Ministry of Health, the Sehatmandi project is the vehicle through which contracts are issued to national and international NGOs for the provision of basic healthcare services. Project funding from the World Bank was halted after the Taliban's takeover in August 2021. In the second half of this podcast, we will focus on South Sudan, and I'll speak to Dr. George Lutwama and Dr. Elko Jacobs. Both work for Royal Tropical Institute in the Health Pooled Fund program. This 5-year program, now in its third cycle, pools funds from donors such as the UK, US, Canadian and Swedish government, as well as Gavi and the European Union. The program supports the provision of basic health services in 8 of the 10 states in South Sudan, again through contracting NGOs and other implementing partners. But in South Sudan's case, this is managed by the Health Pooled Fund Consortium rather than the Ministry of Health. KIT supports the Health Pooled Fund as its operational research partner, and Dr. George Lutwama is the operational research manager, while Dr. Elko Jacobs is the project lead representing KIT. I welcome all three speakers. We'll start the conversation with Dr. Ahmad Shah Salehi as we discuss his thoughts on Afghanistan's experience of contracting out for health service delivery, before moving to Elko and George on South Sudan.
Let's start with Dr. Salehi. Dr. Salehi, in the case of Afghanistan, could you explain how this developed and what trade-offs you witnessed between system strengthening and the aid effectiveness principles on the one hand, and the desire for international donors to account for results in Afghanistan over the past 20 years on the other?
Thank you. I'm delighted to be here. If we look at the evolution of contracting in the context of low and middle income countries in the last 2 decades, we could clearly see that the contract out model has gained extensive popularity, as you indicated in the introduction. It's seen as a promising option to target vital healthcare services, link resources to results, improve efficiency and effectiveness, and also empower communities. In Afghanistan in 2002, the decision to introduce a contracting out strategy was made in a very critical time, just after the establishment of a new government, following an extended period of internal conflict, violence, and war in Afghanistan. So, the main challenge that Afghanistan was facing in 2002 was that the government was not sufficiently capable of expanding primary healthcare services. And this was the time that the quality of care was poor and the health care indicators were worst at the global level. So the option of contracting out and using the potential of the existing NGOs was the best strategy for the Ministry of Health of Afghanistan at that time. Regarding aid effectiveness, the 6 principles of aid effectiveness, as you mentioned, ownership, alignment, harmonization, transparency, and accountability, providing predictable and long-term funding, and engaging civil society, were all carefully considered in the contracting strategy, especially since 2015, as all donors have channeled their funds through the Afghanistan Reconstruction Trust Fund. Over to you.
Thank you. What are some of the characteristics, advantages, and drawbacks of the contracting out model in Afghanistan in terms of institution building?
Thank you. I think this is a very important question, but also this question depends on which perspective you see the situation. From the user's perspective, what's important is to have the ability to access quality health services. From the government's perspective, there is the question of ownership and sustainability, in addition to other key elements such as access, equity, and efficiency. Contrary to the opinions that a contracting strategy might make an organization or a ministry weak, I believe contracting could strengthen the position of a Ministry of Health by allowing the ministry to negotiate the health services terms with implementing partners and to maintain a central role in the management and coordination of health service delivery. And this has happened in Afghanistan. The strategy helped the ministry to practice a stewardship role and focus on health system development. But there were also some shortfalls, particularly in terms of implementation, such as shortage of healthcare workers, inadequate drugs and equipment, and poor infrastructure that have negatively affected the implementation. We also noticed some operational challenges of contracting, such as delays in payment to NGOs and the low capacity of local authorities to monitor the implementation of services.
Thank you for that, Dr. Slay. What are some of the incentives that have encouraged building up and institutionalizing capacity at both the central and local levels?
Thank you. I must say the contracting strategy was focusing not only on service delivery, but also on building the health systems. The financial support provided for the purpose of health service delivery in Afghanistan has always had a component of institutional capacity building and systems development. So using the available resources, the Ministry of Health of Afghanistan paid extensive attention to the development of health systems.
And could you describe how the security situation and rent-seeking pressures have challenged this process?
If I say briefly, political interference has proven a key change to contracting out program, as NGOs had to work with local officials, members of parliament, and other influential members of the community on a regular basis. But also some studies conducted in Afghanistan show that the full package of health services has been provided in more secure provinces in Afghanistan, while insecure areas have only received emergency services.
Now, my next question is something that the rest of the world is agonizing over at the moment, and I think you can shed some light on that. The Taliban regime is not recognized as a legitimate government, and any aid that is given directly to them is viewed as support of this regime. We're facing this dilemma now What do you think will happen if the aid for the primary healthcare services of Afghanistan is stopped?
Yeah, thank you for raising this question. It's quite essential at this stage. I think the issue of legitimacy of the Taliban regime and the provision of aid should be seen as two separate issues. I think there are enough studies showing that the relationship between public services and the degree of legitimacy a government could gain is nonlinear.
Yeah.
I think abandoning support to the primary healthcare of Afghanistan, which is 100% dependent to donor assistance, would compound the crisis, and it will harm the most vulnerable segment of the population in Afghanistan. Let me give you an example. Routine immunization, including polio eradication, is a vital program. Any disruption to the immunization program would threaten the entire polio eradication program in the region. Similarly, any large-scale disruption of supplies and services related to COVID-19 will have massive public health consequences.
And if you were to take stock of the situation now in Afghanistan as it is, what are some of the things that the donor community could do to ensure health service delivery as well as sustainable development and continued institution building?
I think prior to 2002, donors provided direct funding to NGOs for the provision of health services in various parts of the country. So historically, there are creative ways based on humanitarian grounds to directly fund NGOs to ensure the health services continue at the primary healthcare facilities and health workers are paid for coming to work.
So George, you're joining us from South Sudan. How have the dilemmas that Dr. Salehi speaks of between system strengthening and the aid effectiveness principles and the desire to deliver results for international donors surfaced in your work?
Yeah, thank you very much for having me on this important podcast. In South Sudan here, South Sudan is a new country, one of the newest in the world actually. It's over 10 years old, slightly over 10 years old. But before the independence of South Sudan, there was a multi-donor trust fund that was started in 2008, and it was headed by the World Bank then. But during that time, the funding model was a little bit different because the funding was going through the Ministry of Health. So the World Bank would give the Ministry of Health the responsibility to contract out the implementing partners. But with time, things changed because of a number of issues that came up in terms of accountability, in terms of corruption that was coming up, in terms of lack of capacity on the side of the Ministry of Health or on the government of South Sudan, such that the models had to change. When you look at South Sudan and Afghanistan, of course, the NGOs or the non-government organizations are contracted by the lead agents for the donors to provide services in given, geographical locations. However, for the HPF, since the inception, the donors for the Health Pool Fund, they did not want to have their funds go through the National Ministry of Health because what I already talked about, things to do with transparency, things to do with corruption, which came up at the time of the McDonald Trust Fund.
Yeah, thank you. And could you perhaps share an example of a successful institutional building exercise that has benefited from external support within the health sector in South Sudan?
Yeah, thank you very much for that question. I think I can give an example of maybe the county health departments. The Ministry of Health in South Sudan is organized along 3 to 4 tiers. We have the community system, we have the primary care system, and we have the secondary care, which looks at the county hospitals and the state hospitals, and then we have the tertiary level, which looks at the referral hospitals and also the teaching hospitals. So the benefit, I think, has been more at developing the capacity of the county health departments, because for most of the programs that are running, that are contracted out to the NGOs, the emphasis is to follow the county model. So what is happening is the NGOs that are contracted to work within a given location, they are co-locating with the county health departments. And the reason for co-locating is to ensure that they are able to pass on skills. In South Sudan, we have a scarcity of skilled people, both in management and also in service provision. So the implementing NGO, which is working in that particular location, they share the same office. They develop or help assist in developing the skills of people, just like in the supported supervision. In that case now, the county health department is able to take a lead in actually implementation of the health services within that geographical location for which they are responsible, so that their role is not actually taken over by the NGOs. So they're supposed to take a lead. However, they're supposed to be supported in making sure that they have the necessary skills to carry out their responsibilities.
Okay. It seems that the health system and, you're quite dependent on a lot of factors coming together. So aside from the clearly visible effect of funding cuts on access to health service delivery, what impact do you expect from any other fluctuations in funding or changes in donor commitments on institution building or system strengthening in the health sector?
Yeah, thank you very much for that important question. I think this is really a big challenge, like you would say, because with time, looking from the way when the Health Pool Fund 1 started up to the Health Pool Fund 3, where we are right now, I would say significant cuts have been made over the years. So the donor funding keeps on dwindling, yet the government funding is not increasing at any level. In any case, it keeps on also decreasing. From Health Pool Fund 1, all the health facilities were almost being supported with the support of the implementing NGOs or the funding agency. When we came to HPF2, of course, that one continued. However, when it came to HPF3, the facilities that were being supported were drastically cut from about 1,200 to about 800 facilities. And this caused a lot of challenges because access is already constrained in South Sudan, given the lack of road infrastructure, given that many people live in rural, very remote areas where even no facility exists at all. But you keep on also reducing on the number of facilities, which means the access to the services becomes even harder for the common citizen, for the citizens to be able to reach the services where the services are provided. Second, also when it comes to the salaries also as well, there are those people who also lost, I would say, an income because they were not because the facilities were cut, the facilities were not being supported anymore, so they were not able to support their families also as well. Then you are reducing the number of facilities you are supporting. You are reducing maybe the health workers you are supporting in the facility. Definitely, the quality is going to be impacted. That one becomes a challenge within the health sector. Instead of building the system, I think the system tends to stagnate. I can give another example as well. the transition from HPF2, the Health Pool Fund 2 Phase 2, to the current program, HPF3, when actually the facilities were reduced. And those health workers who lost their jobs, actually, they ended up sometimes, attacking, violently attacking the humanitarian workers or the NGOs who were supporting the county health departments within those locations, because they were saying that, for you people, you have your jobs, and for us, we don't have the jobs. So the political dynamics also come in, whereby, you would say maybe the county commissioner or the governor or, or the Minister of Health at that level, at the state level, would come in and say, maybe because we have reduced so many staff and so many health facilities from our location, we don't want you as an NGO to continue providing services to this community. So we are chasing you out of this location.
Yeah, so it seems that the fluctuations do result and fuel instability and violence. Elko, if you were to reflect on the experiences shared by Dr. Salehi and in Afghanistan and George now in South Sudan, what lessons would you draw in terms of opportunities for system strengthening and institution building in fragile and conflict-affected settings?
Thank you, Bipasha, for this question, and thanks for having me on this podcast. So, to answer your question, I think I would agree with Saleh that the contracting out, as it was institutionalized in Afghanistan, overall, you could say it helped to strengthen the system. It had a strong focus on strengthening the stewardship role of the government and a strong focus on performance, rewarding performance, with at the same time day-to-day management of services contracted out. And coupled with sort of the long-term support since the early 2000s, and the joint alignment to a harmonized, the harmonized support and the alignment to a basic essential package of health services, all that really allowed, I think, for also the develop, aside from progress on the front of public health, also allowed for development of really essential capacity and procedures in place at the level of the Ministry of Public Health in Afghanistan. Having said that, I think also just hearing the story from George, these conditions are and have not been as present in South Sudan. First of all, there has not been real clear agreement between all parties on a final basic package of health services, and the de facto package on the basis of which they work, that's supposed to have the health services included that should be prioritized for support, is too broad, allowing for cherry picking and a continuing negotiation on which services to prioritize. I mean, health services like more family planning, or a focus on communicable diseases, or maternal and neonatal health, and that process of continued priority setting and negotiation is a process that donors exert major influence on. Whereas in Afghanistan, that say, of course, there's major donor influence, but at least until the middle of last year, the government was a bit more in the driver's seat there. Also, what's important to mention is that the role of monitoring and evaluation of the health system that was not integrated as much into the contracting out system as it was in Afghanistan, where there was a third party for monitoring and evaluation, so there's an independent party for doing the M&E, which provided essential information to the Ministry of Public Health in Afghanistan to manage contracts for health service delivery. And this M&E role and the prominence of it, the lack of it in South Sudan arguably made the programming less performance-based, because if you don't have good information on performance, it's also difficult to manage for performance, of course. And I think generally you could say undermines the potential for more evidence-informed policy making.
I have to ask a follow-up question on this. There is, George has mentioned, and you yourself, Elko, have mentioned a couple of times about the role of the Ministry of Health in the different contexts and what impact they had. Would you perhaps like to comment on that aspect? That did the fact that in one country the Ministry of Health was not as active as opposed to the other, did that have any impact on the results?
It is a very important question, but also very difficult to answer, because you don't have a control group in a sense. It's difficult to give a really conclusive answer to that. I think there's been a sort of a catch-22 situation in South Sudan, where very understandably donors were reluctant to, and international organizations, to give that contracting role to the government because of bad experiences in the past in terms of corruption, but just that role being removed from them, and all in the hands of international organizations, also undermined any sort of opportunity for them to develop that further, and even the thinking along on terms of what priorities to set in the health sector, that thinking process was done by external consultants, as opposed to supporting the Ministry of Health to make to consider this, to make these sort of choices or calculations for priority setting. Yeah.
If we have to look at the topic as a whole, what are some of the typical challenges and political incentives that need to be reckoned with, according to you, Elko?
So I think, first of all, as George explained, these fluctuations in donor funding and short-term projects, I'd say they really undermine institution building and any sort of efforts for real longer-term sustainable capacity development. They breed fatigue. They're important part of policy fragmentation, duplication, but also can breed alienation, cynicism, and distrust among citizens and what's called street-level bureaucrats. So the face of the bureaucracy towards citizens, the health workers. So in that sense, there's still much work to do around harmonizing donor efforts and harmonizing aid modalities with real longer-term horizon planning. I think it's also good to mention that distrust is also instrumentalized, not only in fragile and conflict-affected settings, but it is particularly detrimental in fragile and conflict-affected settings. Also in times of epidemics like COVID-19 and Ebola, where external for international organizations and health workers as sort of arms of the state are really distrusted, and vaccination efforts or even treatment, for example in the Ebola epidemic, are really distrusted, or even just people working on a vaccination or treatment of Ebola affected people are attacked. I've also witnessed this fatigue and distrust, myself in Central African Republic, where just a history of extreme neglect by the government, but also sort of exploitation by foreign powers has really fueled a great distrust. And I think this can also not be seen in an isolation from the experiences in some of these countries with foreign military presence. Military support for ineffective and sometimes repressive governments has sown distrust, because people would see violence to continuing, human rights abuse to continue, and that sort of brings me to the final point that the political economy, wider political economy, remains crucial to reckon with in any sort of interventions around health system strengthening. So also the character of the economies, resource dependency, the investment climate, the importance of an illicit economy, cronyism, all that affects the rent-seeking rationale within bureaucracy, sort of the patterns of corruption that you see, but also the opportunities for domestic resource mobilization, which George also touched upon.
Yeah, thank you for that, Ilko. Would you perhaps like to say something to that, George, before we close? Or
Yeah, I think I can still give some light on it as well. Just as I wind up, I think echoing what Ilko has said, I think we should also at some point, I think, complement the Minister of Health, like here in South Sudan. I think given the little resources they have been able to come up with the policies, actually good policies, to guide, the Minister of Health at the lower levels. And the best package of health and nutrition services, which is, although it has its flaws, but I think it has at least at some point guided the NGOs to implement the services in South Sudan. So I think they have played a role on their roles as well, but of course they need to be empowered more. So they need more empowerment. Capacity has to be built into them. And lastly, I would like to say also that South Sudan being one of those fragile and conflict-affected settings, and having one of the highest mortality and maternal mortality ratio and infant mortality rates as well, I think the donors should not give up on South Sudan. The people of South Sudan still need the donor support. And I think we need also to encourage the Minister of Health to put more resources in supporting the health sector other than supporting other priorities. I think health should be a priority to all the governments in Sub-Saharan Africa, especially in South Sudan. Thank you very much.
Thanks to all our speakers for joining us and to you for tuning in. We'd also like to thank Harry Coleman for his editing and technical support and Tristan Bailey for providing the opening tune. Thank you very much.
This wraps up this episode of the podcast series. Thank you for listening, and please check out our other podcasts. For that, and to learn more about the World Bank Group efforts in environments affected by fragility, conflict, and violence, please visit our website www.worldbank.org/FCV.